Bastin will start off.
Yes, sir. Yeah. Respected KSOS President Arup sir, other KSOS officials, today's speakers, Dr. Mathew Kurian, Dr. Chandrashekar, other senior members, and dear colleagues. Warm welcome to today's program on NABH. The Assistance to NABH Accreditation is a President's program to help eye hospitals who are willing for NABH accreditation by giving them advices and sharing valuable information. First of all, let me welcome our KSOS President, Arup sir, who is the key person behind this project. Welcome, sir, to this program.
Thank you, Bastin.
We have eminent speakers today. Dr. Chandrashekar and Dr. Akhilan were NABH certified assessors, and they were also part of the team which formulated NABH ECO guidelines. Dr. Chandrashekar was also the lead for NABH complaints of all the 14 branches of Aravind Eye Hospital. At present, he is an honorary consultant for NABH accreditation across the country. Welcome, sir. Welcome, Chandrashekar, sir, for today's program. We have also Dr. Mathew Kurian, who is the head of the Department Cataract and Refractive Surgery at Chaitanya Eye Hospital, Kochi. He is also NABH certified speaker. Welcome, Dr. Mathew Kurian. We also have experts for the panel discussion: Dr. Akhilan, Dr. Jane Chiman, Dr. Devin, Dr. Rohan, and Dr. Jacob Mathew. Once again, warm welcome to all for today's program. Thank you.
Next item on the agenda, Mathew.
I'll start with my screen share.
Just give a brief background, then
Yeah.
start.
So, the purpose of this survey that we conducted over the last couple of weeks on pain points in NABH accreditation was to try and understand what is the current level of knowledge, where people who are either on the path to accreditation or entry-level certification, where they are struggling, or people who are already accredited or certified, where they have struggled in the past, so that the path is easier for the future people who are undergoing accreditation or certification. So this is a very brief survey which was conducted, and I'm just sharing with you the responses to the survey. The experience of the people in their current organizations was equally distributed from 0 to 5 to greater than 20 years, though most of the people who had responded to the survey had more than 20 years of experience as an ophthalmologist. All of them who had responded had at least an MS in ophthalmology, and about 30% were fellowship trained people. The clinical practices from of the people who had responded, the background was more than 50% were in private practices, and about 15% were corporate, and the rest were in group practices. More than 70% of people had both clinical as well as administrative responsibilities in their respective practices, and more than 70% of the people responded had interest in NABH accreditation. There was nobody who was not interested in NABH accreditation. 30% were NABH accredited, the rest 70% were interested in accreditation. So the survey pain points that we assessed, there are many pain points in the whole process, but we were trying to elicit whether there were any specific objective elements or standards which were confusing to people, and it was on the basis of this that this survey was framed. So with regard to referral mechanism to other hospitals, 70% said that it was easy to implement. About 30% felt that it was not applicable, and this is something I think Dr. Chandrashekar will clarify as we go forward. All people found it easy to implement, with regard to initial assessment for outpatients, emergency patients, etc. Emergency drugs, lookalike, sound-alike, high-risk medications were easy to implement, and the informed and general consent processes were easy to implement. So these are good, very strong and important things, and it is good that all the people feel that they are comfortable with this. More than 85% of people found it easy to implement the following things with regard to creating a care plan after the initial assessment, to have SOPs based on clinical evidence-based SOPs. Their processes for emergency, including triaging, was easy to implement. Displaying of patient and family rights, displaying and implementing employee rights and responsibilities were easy. Validation of CSSD and OT processes, that is air quality and instrument sterilization validation, was easy for most people. And the presence of clinical audits and having separate clinical audits and medical record audits was implemented in majority of the practices. And the organizations had a policy for retention of medical records and confidentiality of these records. So this is also showing that across the board, a lot of people had a good amount of information and understanding on how to do these things. Only 15% of people were struggling with this. 30% of people were struggling with policies for administration of anesthesia and discharge criteria after the surgery was over from the recovery area. There was again implementation of a quality improvement program. 30% nearly was struggling, and so many committees are there for both eye care as well as entry-level certification, and how to review these committees and the functioning of these committees. 30% did not have a good clue. Then moving on to energy efficiency and environmental friendly hospital incentives, initiatives, handling of disciplinary actions and grievances, and electronic records that could generate the performance indicators automatically. 30% was struggling. Nearly half was struggling with regard to maintaining a calendar for staff training, facility management rounds, and internal audits. And this is somewhere where, like I think the NABH KSOS initiative will help organizations. Complying with statutory requirements, again, especially with regard to things like, the B-scan, whether PCPNDT requirement is there, all those things are things that people are struggling with. Mechanism for monitoring of outsourced services was a struggle, and credentialing and privileging of doctors, nurses, and allied health staff. This was also a struggle for a good percentage of people. Then more than half were finding it difficult to implement pediatric services, scope of services, as well as Code Pink and other policies required, especially for pediatric services. Then only about 50 to 60% were comfortable with the policies for multi-dose vials, as well as sharing of consumables between patients. And the similar numbers were comfortable with having a safety officer and risk management issues in the hospital. And HR planning was again a challenge for nearly half of the people. So this was essentially the survey responses, and I think these are weak areas or pain points which maybe the KSOS initiative will help to overcome. Thank you. I'll stop screen sharing. Over to you, Dr. Arup. You're muted, sir.
Okay. So a warm welcome to everybody, the viewers as well as the panelists. And thank you, Bastin and Mathew, for taking the lead role in this drive. So if I go into the background of this movement, once I took over the mantle of presidency of KSOS, multiple NABH agencies approached me, and they said that, we would like to help out your organization. And we have also tried a couple of years earlier, but because of the COVID related issues and difficulties and hurdles, this could not take off. All right, then I welcomed their suggestions, their proposals, and then got in touch with the previous office bearers. And they found they indeed confirmed that, there was an effort from their side as well as from KSOS, but Corona came in between. So I thought we'll just take it up in a big way, and all those hospitals which are yet to be accredited, they can take help of this core committee, and then so it was our duty to fix to finalize the agency who will do the job for us, and then we viewed all. It was put up in the group, and we compared the merits and demerits of the various vendors. And then we found out that Dr. Chandrashekar, who we know so well, is an ophthalmologist, and all of us are aware of his credentials and his commitment to these activities. So NABH related activities. So we thought that he is the best person to lead us through in our project. And once at the same time, Mathew conducted this survey that also gave us a good idea about what are the drawbacks, what are the lacunae, so that we know where to focus on, our energies on, which should be the thrust areas. So that's what the survey has revealed. And so I just want to confirm, just want to convey that Dr. Chandrashekar will be helping KSOS for this project. And we have just thought whether we could also include the bordering district clubs, the southern Karnataka or Tamil Nadu, which are bordering Kerala. So they also can be made a part of the project, for which we'll have aligned with the respective state organizations, which we can easily do. But first we'll let us start off with KSOS, and at the same time, we will try to build bridges with the neighboring state societies. So I think this is what I wanted to communicate. What I think you found out, most of the hospitals which were interested in NABH have already been in the process, have already done it, or they've got to renew. And there are a couple of hospitals still left, which have just come up recently after. Then they decided to go for NABH. So there are hospitals which are ready to join the NABH bandwagon. And this thing will be open, I think, for the next year also, so that any new hospital that wants to join, any new private practice or any organization wants to join NABH can go through this channel. So thank you very much for your cooperation to all the committee members. And thank you, Jacob. Jacob has already, got NABH done. Then likewise, Bastin has done it. Mathew has been a leader in this, big leader in this field for a long time, and Gopal is always with us. Jane will be joining us shortly, and the other member Rohan is traveling. Devin was also here. So thank you very much for your inputs that came in our WhatsApp group and the discussions, which helped us to crystallize our thought process and our plans. And over to you, Dr. Chandrashekar, to tell us, us as well as the viewers who are watching in the YouTube, as to what is this all about, and what will be the plan should they decide to enlist with this program.
Sir, is my audio visible? Audio clear and the slide visible, sir? Hello?
Yes.
Yes, everything is clear.
Yes, sir. Yes, sir. So, respected President, Honorable Executive Committee members, members of this committee, and all KSOS members who is watching now or who is going to watch in future, very warm greetings to all of you from our High Quality Online Forum. So at the outset, I would like to thank Dr. Arup, Dr. Mathew, and the team for giving us an opportunity in this wonderful program for KSOS. I'm also a KSOS member. I'm very happy to be part of this initiative. So at the outset, I must tell, this is something. First, I will divide it into two parts. One, why do we need an NABH, or why we need to sustain NABH? The second is how to go about. At this point of time, I would like to say the images examples are from eye hospitals where we have worked and from the net, only for conveying what I want to convey. So what is NABH? Why and advantages, if you ask? At this point in time, compared to 15 years back, NABH is no longer a new terminology or a bad word like people think, oh my God, and the NABH coordinator is the worst villain in the hospital. But it has become accepted in majority of hospitals. I'm also happy to say, I'm sure Kerala has many, many hospitals which are either certified at entry level or accredited. That is fantastic. And the second point is there may be a few hospitals who have to go for NABH, and there may be a few newer hospitals who will be coming up shortly. Though I am a qualified myself and Agilan are certified assessors, we have got DM panel to do this online training and implementation as consultants, number one. Number two, I was also part of the NABH eye care organization guidelines, which was created, standards. I was part of the committee. At this point, the recommendation is you don't take any consultation at all. You have to do it by yourself. That is the best way to go for NABH. However, for that you need some manpower. A person who's well versed with NABH, a person who has got a lot of experience who can take over the implementation. Many hospitals have done that, especially bigger organizations. But smaller hospitals will not be equipped so much. The cost of getting a consultant will be much lower than employing a person and paying him the same amount every month. So that is only where we will play a role. And the second thing is they get entry-level certification. The next 2 years, they forget about the processes. And when they go in again for a certification, the initial agency which helped them won't be there. So there also you need for re-certification or accreditation, some kind of help, and some of the processes are left. It would have been done only earlier for the sake of getting NABH, but it is no longer advised to do that. Apart from that, smaller things, there may be, for recently there was a hospital which contacted us for final NABH eye care organization. They had 59 non-conformities. Another hospital had called earlier with 70 non-conformities. Entry level can go anywhere up to 20, 30. So closure of NCs also we can give our consultation. But if you can do it on your own, there's nothing better than that. So ideally, at the end of the day, you want to give optimal quality treatment to the patient with absolute safety. There are many things about safety which I will talk later. So nothing against any person, hospitals or clips. It is only used for showing what I want to do. Initially, the doctors were God. From that era, now we have gone into the patient-centric care, and now we are further going into a multi-centric approach. For example, you have a endophthalmitis, you do not refer to a VR specialist if you don't have one. That becomes a mistake. That is how things are no longer. MBBS doctor can even do a closed valvulotomy for mitral stenosis. So that is how it has gone now. So if you see, there have been many cases of incidents, trauma, infection across the country in many hospitals. Every incident gets blown up by the media sometimes, and that becomes a major headache. Wrong patient, wrong eye, wrong surgery, which should never ever occur. It should be 0%. Roof falling on somebody, that has occurred. Medication errors are not at all uncommon across the world. Forget India alone. Cluster endophthalmitis, fire, loss of life, and so on and so forth. Medication errors are the third most important in US compared to next to the heart disease and cancer. So much occur. It is not only while giving, from the time it is prescribed to from the time the patient takes or it is administered. A plane, traveling in a plane is lot safer than getting treated in a hospital. It is unbelievable, but that is the truth. We have so much of security in man. These are two hospitals, one in the north and one in the east, which had fire. Even the owner was arrested. Some of them have got, they have got completely lost the license and no practices there. But if you look at this is Columbia and Bangalore, which had a major fire a few years back. Within 15 to 20 minutes, they evacuated everybody. Not even a single person was injured. There was only a little bit of damage to property. This was about 3-4 days back in Rajiv Gandhi Hospital, General Hospital, Madras Medical College in Chennai. There was a major problem near the neuro block. It was a huge fire from the basement. Oxygen cylinders were getting blown off. And the doctors, nurses, including the professor who was my own classmate, they shifted all the patients efficiently without a damage to anything, without any problem to any of the patients. Everybody was shifted safely in spite of a big fire, except that a few doctors and nurses had little bit of, because of the smoke they were inhaling, they had little bit breathing difficulty, but they were treated. So the process will not come just like that when an incident occurs, unless we are prepared for it and have done your course. Basically, why NABH is important? Because it is a governmental organization under the Ministry of Commerce. So it's a constitution of Quality Council of India. So NABH has got all the powers being part of the government. It benefits the patient, that is number one, in all ways. And they also, in the long run, today, every patient goes through the net and comes, and they will understand their credentialed staff who will treat them. And it will benefit the staff. We don't mean the money alone. It is their health, protection from safety, everything is given and it's a continuous learning process. And of course, it benefits the organization, gets a brand name, and it runs at an efficient. Initially, there may be a cost, but there is a lot of efficiency and reduces the cost, and it is very useful for the management. It is a standard practice, gives a recognized brand name in the court of law. If we can prove that we are following NABH elements or NABH standards, because it is certified by a governmental organization, it will stand better than any other principles. Example, endophthalmitis, any other protocol. There are UK standards in India, many states and many, even in the top level they give, but that will not be as good as the NABH. It will give a lot of weightage. Okay, I'll come to that a little later. Any happy patient will definitely bring in 6 other patients. This is definitely one of the statistics got from various studies, but one unhappy patient will prevent 26 others from coming. This is something which we have to remember, whether NABH or not, we have to give the care. Happy patient will bring 6 others definitely. And then came the Insurance Regulatory and Development Authority of India. They made it very compulsory, and even the other insurances in various states, it is essential to get at least entry level. In fact, IRDA and NABH combined together to start the entry level certification program, so that there is basic minimal program, minimal level of quality safety in the hospital to get IRDA approval. They are extending it year by year. At one point of time, it may stop. So we have got many hospitals who got entry level certification, for which this triangle is the logo. Next, we have this AOS committee. The AOS initiated NABH. Eye care is the first ever specialty to get a separate standard. I'm very happy to say that we were all part of the committee. For 1 year, we worked to get this eye care guidelines in place. It is definitely a boon. It gives weightage for nursing and paramedics. We don't have to get as many nurses so much. Then we have other things, sharing of consumables, and so many things which will be very well addressed in this ECO guidelines. So these are the 2 entry level. So we need to understand why this entry level. Why this entry level is only a certification program. It is not called accreditation. It is valid for a period of 2 years only. Whereas the accreditation program, you are accredited, valid for 3 years. You have to keep sending reports in between to NABH. Entry level, you are certified as per the standards on the day of inspection. Hardly they have any surprise visits or anything. Anything below 50 beds is small healthcare organization. Anything above 50 beds is a healthcare organization. Just to make a difference, you can see there are 302 elements. 302 elements in ECO, whereas the entry level will have 149 or only 167 elements. It's almost half. So it is not that difficult also. So there are about 10 chapters, and we have various standards. We have 169 elements for healthcare, and on 167 elements for healthcare, that is above 50 beds, and 149 for small healthcare. So there are so many things. For example, if you take there's the first 5 chapters of patient-centered, next 5 chapters are managerial-centered. So if you take this particular first standard, which is called access, assessment, and how you have a continuity, there are 7 standards. Just to give an example, what is an element? In that access, assessment, and continuity, services being provided are clearly defined. That is one element. So out of the 149 for a small healthcare, we have service defined. Where will be defined? In the manual. Okay, so definition is done in the manual. It can be clinical service. I have general ophthalmology, retina, uvea, glaucoma, and orbit. Supportive service. I have laboratory, optical service, pharmacy, canteen. That's all. Where will you define? In the Apex manual. Then you have pediatric, then you need to have a separate scope and so on and so forth. In display, it is always done in 2 languages, which even without any NABH, everybody does it. English and then the local language, minimum 2 languages. There should also be pictorial. Some of the specialties you cannot put pictorial. They also advise, if possible, there should be some website also. Patient should know when they enter, or anywhere they should be able to find out. And every year you may add or remove a specialty. Oriented, anybody who coming in contact with the patient should be well oriented. Will they give cancer treatment for the eye? Yes or no? Something similar, they should be able to give a relevant answer. And everybody should be trained on the scope of service. These are the 3 elements out of 147 elements. That's all. So simple it is, but it has to be implemented methodically. All these things are statutory. First and foremost, you need to have the Clinical Establishment Act, which all the hospitals have now. Then Pollution Control Board for biomedical waste, air and water. If you are doing a transplant, you need to get a HOTA Act and IBank license. Pharmacy, 100% you need to have, along with the pharmacist license only. Without a pharmacist, you cannot have a pharmacy. PCPNDT, as Dr. Mathew said, there is a court order from Delhi High Court initiated by AOS, which is still valid till the next hearing, that this is not necessary for B-scan of ophthalmology. So like this, these are some of the things. Then you need for lift, you need for a diesel generator, a boiler, a canteen, and so on and so forth. Then you should have a tracker. License tracker should be there. What is the license? Who will track? When it is? So that we don't miss at any point of time. You should not have a license which is not valid. At that point of time, if you have any complication like a cluster, like a flyer, and it becomes a public issue, even if you have done everything wrongly, absence of one statutory license is enough for them to even shut down the hospital. So you please make sure none of the statutories or legal go out. So if it is not documented, it will not be done. Everything we should write how it will be done. We should say what will be done, and whatever is done should be registered. So like this, green color, look alike, sound alike, this is there. We have it in the manual, we implement. If it is not recorded, it is not done. This is the mantra of NABH. Not documented, you will not do. I don't know, you have not documented how to do NCT, that means you are not doing NCT. Even if you do, it will not be taken into account. So then a documentation, which is most important in any of this accreditation, ISO or anything. So Apex manual is the Bible of the hospital. Then the procedures will say department manuals. In small hospitals, we don't want department manuals. We need only the chapter manual. Then work instruction, how to actually do this, how to record a BP, how to go ahead and do NCT. Everything will be there in the form. Then we have records and forms. I'll show some examples. These are some of the things we need to document. And then you have the statutory document, regulatory and statutory document. Small hospitals, we need to have manuals. These are something which will tell how to do, what to do, who should do. And when there is some problem, what will be done. That is enough for 11 manuals, the 10 chapters from an Apex. But in larger hospital, you need an Apex and multiple departments. You have retina, cornea, store, pharmacy, facility, and so on and so forth. It may come up to 25 to 30 manuals also. That is when it is a bigger hospital. Accreditation, we need to have that. Registers should be beautifully, everything will be standardized across it should be numbered, there should be something, how long we will retain it, who will be in charge. Some of the things will be even lifelong. So this will be standardized across the institute. Forms, again, we have the forms. This is credentialing of doctors. I know MBBS verified, DO verified. Sometimes there are people who have not passed, come and said they have passed and worked also, and they've got into legal problems. Then, you know, what we do, what we privilege them is based on the experience. We say they can do DCR, they can do DCT, they cannot do a endonasal DCR like that. So this is about the form, how you make it. In healthcare, there is something called structure, the process, and the outcome. Staff, patients, equipment, and all other major structure, processes, nursing order, doctor's order, or processes. Ultimately, after the treatment, what comes is the third process. Hospital acquired infections are very important. 75% are accounted by 4 categories, primarily the procedure and devices. For us, the most important is the surgical site infection, which includes the endophthalmitis. But many of the eye hospitals, those assessors who are non-ophthalmologists, they come and ask about the Madras site. Conjunctivitis patients, do you have some facility so that they do not spread it to the others? Definitely, many hospitals try to do something, but there is no separate facility. There sometimes many of us would have seen they come for a refraction and 3 days later they would have come. They will come back for conjunctivitis because the next person sitting to him or the slit lamp was not cleaned or something like that would have happened. So infection control is primarily important. If you see all these processes, whether you're going to handle, how you are going to handle the biomedical waste, hand washing, then you have to, how you take care of the instrument cleaning in the theater, then spill management. Most importantly, antibiotic policy. Our antibiotic usage is very minimal, but if you have orbit of cornea, you unnecessary, even for cataract, antibiotic policy is needed. There are some, we have gone from the era of using antibiotic steroid for 6 weeks, which is not advised anymore. Not more than 5 to 7 days postoperatively, even topical. So all these things have to change with the change in principles across the world, because the animals and are given more antibiotics than human beings. And there are many factors that give rise to antibiotic resistance. So that is an important component, especially for example, first line, second line, after culture, what do we do, where we de-escalate and so on and so forth. That is about antibiotic policy. Safety, normally when we talk about safety, we think only about fire safety, but we can have a physical safety, fall from a roof, you have pointed wires, a nail. So physical safety, fall from a steps which doesn't have a proper hand railing. Surgical safety, in all the bathrooms should have, we have hand grabs, bars for them to walk across, and coding. So fire safety, surgical safety, WHO surgical safety checklist, which is basically before the anesthesia. For us it could be topical, we make a checklist. Then before putting the incision, we'll do a checklist. It should all be read aloud. Then after surgery, before shifting from the theater, so sign in, time out, sign out. If they do all this, we can prevent many complications that can occur, sentinel events that can occur. So chemical safety in the lab and cleaning solutions, hospital infection safety, medication safety, and all this will occur only if you have a standardized protocol, good checklist. See, this is the model of Swiss cheese. Many holes are there in each of the Swiss cheese, but each one will get blocked somewhere or other. But there is one hole which will come through completely. If patient, doctor see, counseling in the ward, before block, before preparing. Any point they find out it is a wrong guy or wrong procedure, they can stop. In spite of missing all this 5 checklists, then the patient will be harmed. That is the principle of any checklist which will prevent any harm from occurring to the patient. So these are codes. We say code red is fire, code blue is cardiac arrest, and then child abduction. Many people in the hospital think I do not have pediatric services. Dr. Mathew said pediatric, they're having difficulty. If you are seeing any patient, definition may say 15, but actually it is 18. If you're seeing pediatric patient, then code pink is must. There is always a chance of a child getting abducted. So these are the trainings we have to do mandatorily. You have to train BLS every year. They have to get certified. Don't know. 1 in 10,000 we may be able to save a life and send to a advanced cardiac life support. We may be able to save a child. We are in fire, shifting. Unless we have done the drill, it is not possible. We do not know what to do, but if you have done at least 2 drills a year, everybody will be efficient. Today, they also include 2 non-fire emergencies like, flooding, electricity leak, or mob attack. That can be done. Bomb threat, you should have something. Sometimes an aggressive or a violent patient, code purple. Everything, unless we have a process in place, we may not be able to come out of the crisis. But we cannot tell 100% fire will not come. We cannot tell in an eye hospital nobody will get cardiac arrest. We cannot tell a child cannot get abducted in an eye hospital. So these are all mandatory and people should be aware. The committees, now there are 4 or 5 mandatory committees like quality and safety, number 1. The second one will be infection control committee. Facility will come under quality safety, infection control, medical records committee. These are 3 important committees. And then pharmacotherapeutic committee, how you can procure drug, how it will give, what will be there, adverse events, and all those will be recorded. Apart from that, if you are giving blood, you need to have a blood run. So these committees only will take over at one point of time and run the hospital in a wonderful way. So that functioning is very important. Audits, we have to periodically, we used to say work. No longer it is true. We work, we audit and work. If we don't audit in between, somewhere we will be losing out and we may land in a crisis. Different for medical records, we have audit, facility inspection, everything should be audited. That is important. Internally, we do it within ourselves. Sometimes before going for final, you can call somebody from outside to audit. Because what you're thinking will be totally different from an outsider who can actually give you the correct view. And then, of course, third party would be like NABH, CGHS, and so on and so forth. What are incidents? It could be, an error. Error could be a wrong drug given. Incident could be a sentinel event, patient having arrest, having endophthalmitis, wrong IOL, patient dying. Near miss, at the last minute, we found out it is not the right eye, it is the left eye and stop, then it is. If you don't analyze any of this, we will keep on getting these kind of incidents again and again and again. So we have a principle of how we will manage. You need to find out what is the root cause, why this occurred, as it occurred before. We have to address that, do a corrective action, and in future, you should never ever get that. You should never ever get it. You have to do a root cause analysis, corrective action, and preventive action. These are all things which not necessary only for NABH. It should be good for any NABH hospital, anywhere we deal with patients. So the general perception for NABH, people think it is a very difficult process in the beginning. They don't think there is any value to it. And we do it for the sake of getting the certification or accreditation, difficult and costly. When in reality, what happens, once you get it, you know your audits, your improvement in efficiency, your documentation. Medico-legally, it will give you so much of weightage if you have your proper consent form. So many things are there, cost effective. It gives a wonderful image, reduces the risk for not only the patient, for the staff, and the management will always gain. This is about basically why we do NABH. How do we go about it? It is not very difficult. Initially, we need to analyze a hospital, whether the statutory legal things are in place. Infrastructure, especially the theater, where you have the theater, whether your biomedical waste, liquid waste, everything is going properly. What is the actual level of documentation that is available? For example, 167 elements will be there in your entry level, or 147 or 149 will be there. You have to see how many are already addressed. Then it's not self-assessment, checklist given by the NABH. You have to see implementation, how it is going on. Statutory needs, which I've already told, registration, biomedical waste. Some hospitals have X-ray, AARB, PCNDT, all those things should be taken care. Now, apart from that, how do we go about? Most important, management should decide we want to go for NABH. It is not just a decision. They must understand what is the gap. Once the gap they know, they will also know what infrastructural changes. Newer hospital, no ramp in Tamil Nadu will not get a license after 2008. So some infrastructural changes may be needed. HR, you may not have a qualified nurse at all, but a minimal number of qualified nurses, because only the licensed nurses can give an injection. Only the licensed nurse can actually do certain things and assist anesthesia. So then you'll need some of them, but not as much, General rule is for every 8 beds, you will need 1 nurse. But in Clinical Establishment Act, for every 30 beds, one nurse is enough. So those things has to be taken. Once they give the approval, next is to identify the quality manager who will be the core person to take care of this and be a link between the NABH implementation and the management. Then you should have a core team with a doctor, with a senior nurse, with a facility person, with an administrator, and at least 4 or 5 people. They will become the core team. Then they will go and do the training. The training can be done if the coordinator is already experienced, or you must get a third party to do the training with many aspects, implementation, the training, and then once you start the training and parallelly it occurs, work should be delegated. One person cannot do entire work. End of the day, coordinator knows everything, others do not know anything, is equivalent to not doing anything. So definitely everybody should know why they do and what they do, and documentation will occur. Then of course there are other things. You have to form the committees, and the committees will take over at that point in time. So some of the HODs will come under their committees. Then HR needs the most important, having a profile. And as Mathew said, HR training calendar, very difficult to implement. That is, there are certain things you have to mandatorily train every year. So HR is a major work. Facility inspection round, we call it FIR, from the lift room to the door gate. You have to, at least once in 3 months, you have to do. Find out what are the faults. Just don't leave with it. After 2-3 weeks, you have to do a follow-up round to make sure they are all corrected. That is most important. The code drills for red, pink, and blue, you have to do. Quality indicators. These are indicators which will say how your hospital, simple. Waiting time was 45 minutes, 1 hour and 45 minutes in retina. Now it will go, it has to become less than 1 hour, first step. Second, we'll make it 45. How you will do? You can give appointments. You can segregate them. You have preliminary. So many things, everything can be done. The quality indicator. How many times you have got redo tests? How many times you have failed in the infection control? All those are quality indicators. Audits can be for medical records, drug prescriptions, and of course, internal audit and all those things should be done. Mandatory training. Everybody should have, there are at least 50 to 60 questions where people should know answers, which can be asked practically also. Fire safety training is every year mandatory. Infection control will be minimum once a year. Corona comes, you have to do more. Basic life support in the hospital, unless it's an accredited hospital, you may need a advanced cardiac life support also. And work-based. For instrument division, they need separate training. For people who are in the pharmacy, they may need separate training. Like that, these are mandatory training. This is last. Internal auditing and self-assessment toolkit is very important. You have to find out where we stand. Initially, you do where we stand. After 4 months, you will do where we stand. Just before application, you need to know you are in place. There are 2 things in it. Like how you do self-assessment checklist. Here you can see services being provided. That means it is there in the Apex manual. Then you have the reference Apex manual. It is there. Everything is there. You have put it across. Whether the board is there in the entrance areas, 2 entrance areas. Whether staff are oriented. So you have to say where it is, what is the reference, put the image. So this self-assessment toolkit for all the 149 elements in the small healthcare should be completed. So you give 5 marks for documentation alone, 5 marks for implementation. If both are done, we are getting 10 marks. Okay, so that is how we grade. Ultimately, we will know where we stand at the end. For entry level, this is a wonderful platform. It's called HOPE, Healthcare Organization Platform for entry level. It is directly done by the Quality Council of India. It is quite simple to organize. There are some things which can fill in the desktop and some from the mobile. Everything is evidence-based. And NABH accreditation also, most of the things can be done online. Ultimately, once this is done, it is done wonderfully. So lastly, you must also know what is the fees. If you are going for eye care organization accreditation, in eye care organization, we have not developed beds at all because many hospitals are only daycare centers. So there the categorization is based on the number of procedures per financial year, April to March. Now, if it is less than 500 procedures per year, application fee is 10,000 and annual fees of 50,000. This was released last virtual assessment 3,000 plus GST always. Okay. Similarly, 500 to 1,500, it becomes almost double, 20,110. Then it becomes 25,000 up to 10,000 and 1,40,000 up to 10,000 surgery. More than 10,000, it will be annual fee. That means for 3 years into 3. Okay. So apart from that, entry level is very, 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 very economical. For entry level small healthcare organization, which you can see at the bottom, is only 21,000 for 2 years. Almost 10,500 only per year, plus of course tax. Assessment is again 5,000. Whereas for a hospital which is bigger than 50 bed, we'll pay 52,000, that is equivalent to 26,000 per year and 5,000. Of course, now they have started again on-site assessment. They travel. So when they are coming, it is the duty of the hospital to take care of their travel, lodging, boarding, and other needs of the person on actual basis. So it is not given by NABH. So this is the fee structure. So NABH is not a difficult thing. Once you have done, only thing is getting NABH certified or accredited is not the destination. It is the beginning of the journey which has to continue as long as the hospital functions. So this is in short about why NABH is important for us and how we can go about. So I thank the Honorable President, Executive members and KSOS members for their patient hearing. Thank you very much, sir.
Thanks a lot, Dr. Chandrashekar, for a
Yes.
very beautiful presentation. It was brief and almost everything was touched upon.
Yes.
So I would request the panelists, if they have to get some more points from Chandrashekar or the certain things which require more emphasis. Bastin, Mathew, Jacob, Rohan.
Thank you, sir. Dr. Chandrashekar, it was a wonderful presentation. And I have a few doubts. Like, first one is, when can a hospital apply for NABH accreditation? Like, suppose I start a hospital today. So, is there any
Time frame? Yes, sir.
Yeah.
So ideally it will take 6 months, sir, because most of the data they will ask will be 6 months, and you start from day, limit is earliest is 6 months, sir.
Okay.
Earliest, because you have to have the implementation, training, data, you have to capture quality indicators and so on. There are two options in this, sir. As I said earlier, certification for entry level, accreditation for ECO. Accreditation may take a longer time. And a certification we can even do within 4 months, after the desktop assessment, everything. 6 months is ideal, sir. I'm sure Dr. Mathew will also agree with me.
Yes,
Yes,
it will take a minimum amount of 3 to 4 months to get the background data into place. And then you can complete the application, continue to collect the data. And by the time they come for the audit, whether virtual or physical, it will be at least 6 months. And at least 6 months data is what NABH requires from us.
So
See, in this,
yes, sir.
in this connection, Bastin, just continuing the same subject. Now, this inspection or this accreditation process, does it happen in cycles, like exams happen every 6 months, every 1 year? Or as soon as a hospital has filled in an application, submitted it, some team will come and do the needful?
Sir, now I'll go one by one. For eye care organization, there is a accreditation process that will occur once you apply. There is something called pre-assessment. So for example, if you are running a hospital, 2 people will come for 1 day and they will do a random assessment, not all the elements. After they do the accreditation random assessment, they will say these are the non-conformities. Based on the problems with the statutory and the non-conformities, they'll fix up a time period of 2 months or 3 months, depending on what you need to do. And then you can go for the final accreditation. But now there is a process where you can say, I don't want a pre-assessment. I can go directly for the accreditation process. So that can also happen, but a pre-accreditation is better so that you'll be better prepared. In the accreditation process, if they come, the 2 people, mostly the same 2 people will come for 2 days. Even if it's a small hospital, every element of the 302 will be checked. So these accreditations are all valid for a period of 3 years, sir.
So my question was, and does it happen like that? It happens every 6 months, every 9 months.
For what, sir? No, 3 years only, sir. But in between, there is a surprise audit. No, there's nothing. Whenever you apply, they will come, sir.
Okay.
It is not any fixed date. I apply, no. Within next 4 to 6 weeks, they will call you for a date.
Okay.
Then fix up. It is a continuous process with the NABH.
Okay.
It is not like NABH or PG exam or anything where only every 3rd month, 6th month. This is a continuous process.
Okay.
In between, there will be a surprise audit. They will just, even the assessor will not know where he is going. He land up in Coimbatore. Morning, they will call him and tell, go to Arvind Hospital. Morning, they will call Arvind and tell Arvind and say there. This is more common with accreditation.
Okay.
There is nothing, yes.
One thing which I would like to clarify is that once the hospital has applied, they are supposed to upload their documents, which includes the statutory. The accreditation committee, those people will scrutinize your documents, and only if it is complete in certain basic parameters does it go to the assessor, and then the assessment schedule is created. So I have had situations where in 2021 and all, I was doing assessments for hospitals which had started the application process in 2018. So if you look at the prior conversation between NABH and the hospital, there will be a fire safety which is not uploaded, or there is a license, clinical license which has expired and for which a fresh application has not been taken, those kind of things. So unless those minimum things are complete, the accreditation process will not start, the audit process will not start. Once it is complete, it is pretty rapid after that.
Okay.
Absolutely, sir. Accreditation, these statutory major things will be looked. This is basically what they call a desktop assessment. But for entry level, we need to upload 180 of the elements for small healthcare and 220 elements for big healthcare. So there is a 2 desktop assessment cycle. Only if the desktop assessment is cleared for complete NABH standards, then they will have an on-site or online assessment. I hope it's a wonderful platform where everything is done. If you have done it properly in desktop, then NABH assessment will be a walkthrough. So accreditation is a lot tougher than entry level, sir.
So, sir, one more clarification. Is ramp necessary for accreditation?
The ramp for fire safety is as per your fire safety guidelines of your state.
So NABH doesn't require ramp.
NABH, actually, the NABH is giving certain minimal requirements, sir. Now, I'll talk a little bit about fire safety. See, basically what we say is no objection certificate or a license from fire department to say you're fire safe, which is for small hospitals in the district level, high-rise buildings at the state level. But entry level, there are some hospitals who cannot get this fire certification due to some infrastructural problem. In that case, for entry level, the NABH will accept a credentialed third-party license, third-party approval. They approve, get it also, sir. I have done it for a couple of hospitals, but they will come and see and say you need, at the basement, you need sprinklers, definitely we need smoke detectors for any hospital. So they will say these are the requirements. Once they complete, they will give you a letter. It should be a credential. Even CAHO, there is an organization which certifies hospitals for fire safety. But accreditation, you must have a fire department NOC, sir.
Okay, so if the fire gives NOC, the ramp is not necessary. That's what I
in Tamil Nadu, buildings after 2008, which have been constructed after 2008, ramp is mandatory. Ramp is mandatory. So they will they will not get a license at all.
Bastin, the issue is NABH says that you have to meet the statutory requirements in your area. So since fire, there are small variations state to state. The requirements for Tamil Nadu is slightly different from the requirements for Kerala.
Yeah, okay. Yeah.
So now this fire occurred, no, sir, in GH Chennai. The health department have told, inspect all the hospitals across the state immediately. Look for fire safety. This happened before also once. because it's a major thing, sir. It can be very disastrous.
So there is this in FMS facility management chapter. There is fire is one big portion. So fire and non-fire emergencies. So non-fire emergencies, Chennai, for example, a couple of years back had to withstand floods. Kerala has had to withstand floods 18-19. Okay, and this has affected many hospitals also. So we have to have plans to evacuate or do based on multiple scenarios, and the National Disaster Control Program, that is a good website source, resource to look for these kind of things.
And there is a document by NABH which says minimal requirement fire safety depending on the size of the hospital. I can share it with you or Arup sir, which you can go through, sir. It is given by NABH itself.
Jacob, you wanted to ask something?
Say you muted.
Please unmute yourself.
You want to add the fact that, when you're going in for it, have a proper plan, as was mentioned here already. And once already, if your documents are in place, and other than the doctor, there should be one person who in the administration who takes up the responsibility to compile all these things, make sure that all the teams are formed, and then periodical meetings of these coordinators should be there, as well as teaching sessions which have to be conducted so that the staff are trained in all these drills and things like that. So that's what we have done. So over a period of 6 months, 6 to 8 months, we need to prepare ourselves for all this sort of things. And, it's actually a very nice way of actually bonding the staff also. The team comes together and we learn things to do it, practically how we should do it and things like that. So doctors are already trained in CPR and such procedures, but then when it comes to the real things, so actually we had a lot of help from the Ernakulam General Hospital, which is an NABH accredited hospital. They have a separate team for that, and we took the help of experts from there, from that team who used to come and take classes for us. Even the fire safety department team came over. They did training for us. They told us how different kinds of fire extinguishing methods are there and what kind of system is required for our hospital, which all spots needs to be covered and things like that. So do it in sincerity rather than just trying to get a certification. I felt it was a very good method of binding together the team, training them, and though just qualifications on paper doesn't really matter, they should know what they should be doing as a medical team. Thank you, Dr. Chandrashekar. You presented all these points so well.
Thank you, sir. Thank you.
Thank you.
Thank you, Jacob, for this wonderful insight. See, there are a few other pertinent questions, Dr. Chandrashekar. Now,
Yes,
when, like, for example, HR documentation is happening, let's say I look after, I don't have anybody else looking after glaucoma. So when I tick, so cataract and refractive surgery, and the same person can also tick for another department, or you need to have a different head. And this is not only for medical care, but it is other specialties also. For example, an optometrist has an operation theater duties. They're trained actually, so they do optometry work in non-OT days, and OT days they do OT assisting and instrument maintenance. So can the same name appear in different groups when you form these committees?
Yes, sir. Now I'll come to that, sir. This is very, very important when you're going for accreditation. Okay, sir. So we have something like credentialing. In credentialing, you will say MBBS, MS, DO, everything. And your fellowship in VR surgery, fellowship in IOL, and all this has become very common now. But if you take our generation, we did not have anything like fellowship. We were trained, due to experience. So there are two things, how you privilege them. The privileging can be done by the head of the institution, either by the virtue of fellowship or by experience. You can say VR surgery, his experience is 10 years, he can do. By privileging, you can say your experience is glaucoma, cataract, refractive surgery. So you can show your experience and they won't tell anything. But without a VR surgeon or a person who's not there, we cannot run a VR department. So you may have to show visiting VR surgeon, his entry should be there, his signature should be there. So what is necessary for VR would be your OCT, your B-scan, your FFA, plus your VR surgeon. So these are minimal requirements to call yourself as a specialty. So in eye care accreditation, so I told you scope, no, so there is a fourth element. You must say what are services not being provided. Example would be, I'm giving VR, only medical retina. We are not doing surgical retina. That is number one. Pediatric retina, surgical retina we do, but we don't do tumors. So those things based on, you can, number one, people who are privileged will be, one will be the doctors, sir, done by the HOD or by the department head. Two will be the qualified nurses. All the qualified nurses, you must privilege them. Now for eye care, we can privilege the paramedics. That is where your question comes into play. Based on their qualification or based on their experience, you can privilege them. But even now, some assessors will say the surgery cannot be assisted other than qualified nurses. Nobody else can assist. So basically, we use for injection and assisting GA. These are small controversies, but you can privilege paramedical. So for example, refraction will have a separate privilege. Ward sister will have, OT sister will have. So you can privilege paramedics as per eye care guidelines. That is how we can make them do multiple things. How you will privilege them? First year people can do like this, third year, above 5 years, they can do everything like that.
So multitasking is allowed. Multitasking.
Multitasking, yes, sir. The smallest hospital is 1 doctor and 7 staff. They got accredited, 8 staff, I think, accreditation.
Okay.
That is not a problem. As long as you prove on paper that they are entitled to.
See, another question.
There is one point there. Supposing you are operating as a single surgeon in the theater, you must have another person trained in BLS for emergencies. There should be somebody else, at least somebody who knows BLS properly. Actually, eye care accreditation, they say you must have a physician or a anesthetist. But in entry level, they don't insist.
Okay.
Yes, sir.
See, the other question was, it is easy to start off the whole process. But what we have noticed that even if you don't have NABH, but you still have strict SOPs and other things, and moment you feel that everybody has learned it, and your own quality auditing level comes down. In fact, invariably you find out that there is a violation from the junior staff. So, what is your experience? Jacob and Bastin, Mathew, and Dr. Chandrashekar. How to tackle this? And this is something that may come up.
Sir, you want to tell or can I?
Yeah, please.
Sir, basically, sir, 100% first time we get a certification accreditation. From there at Himalayan peak, it will come to middle of the bar. Because till then we would have finished them off the last 2-3 weeks with the intensive training. Then completely there is no follow-up on the person who's coordinator or the supervisor. Slowly it will come down. Some of the documentation, what you have implemented may become permanent because the management and the periodic auditing. For example, we do medical records auditing on a daily basis. On a daily basis, we do random audit. Based on the number, we take a sample and audit. So if you don't give the feedback periodically and audit, this will fall. At the end of 2 years, when you want to go for recertification, it is almost like starting from 20%. Okay. It is a bigger challenge. And what would have happened is attrition of staff also will be there. Many of the people who were there in implementation would have left. And in between, they would not have 100-1 training. So sustaining it is more important than getting it, sir.
Okay. Okay. Thank you.
Yes, sir.
Any further questions, contributions? Mathew, Bastin, Jacob, Rohan?
I think I can just add that training, because the ideas that come in when you are going for first accreditation, that energy will never be sustained unless the top management drives the quality team and ensures that training is happening, and regular feedback on the basis of training and the audits have to come to all the people to know that they have to maintain the standards. So otherwise, like they said, there will be a gradual decline. Then just before the next audit, interest will go up. Then again, it comes down.
There's a question for Dr. Chandrashekar.
I saw that, sir. As a solo surgeon, yes, sir. You can't actually, you can say, because you have to show your experiences and your fellowship program. There is no problem. No problem.
Is to have a skill competence matrix. Say that, to do vitreoretinal surgery, the skills required are so much, and then the competence with so many years of experience, so many number of surgeries done in the past, I am competent to do that job. So on the basis of that, you can credential yourself, privilege yourself.
Thank you. So I think, we have almost come to the end of our session, lovely session. So our team, KSOS subcommittee will, get active to recruit the hospitals which are interested in this particular, collaboration with Dr. Chandrashekar and his partner. And so Mathew and Bastin, Jacob, myself, Rohan, so we'll put a drive. And then we have already heard about, the so-called terms and conditions from Dr. Chandrashekar, which is a very, very, competitive and very favorable towards KSOS. So, and then we will get in touch with Dr. Chandrashekar and we'll set the ball rolling right away, so that, we can fast track, the whole process.
It need not be full implementation, sir. It could be renewal, it could be closure, it could be any kind of help regarding NABH.
Yeah.
Specific trainings like infection control.
So Mathew and Bastin, you have collected all the necessary relevant information we require from Dr. Chandrashekar, right? About the terms and conditions. They're with you, isn't it?
Yeah, I will share that PPT with you, sir. I will share it.
Okay. I know what it is, but just
I will share it with you, and sir, we can share it with Dr. Mathew and Jacob, Dr. Bastin. Yeah.
Okay. So any other matters, the questions? So thank you, Dr. Chandrashekar.
Thank you very much, sir, for the opportunity.
The weekend Sunday, which is a weekend time. And thank you, the committee members. Thank you, Rohan. Rohan is traveling. In spite of that, he took the interest and joined us. Thank you, Jacob, Bastin, Mathew.